And the floor is yours, Emily.
Hi, thank you. My name is Emily Crocetti. I am one of the clinical faculty at West Virginia University Family Medicine in Morgantown. I'm also one of the clerkship directors for our third year medical students who stay here for their clinical rotations. All right, so without further ado, we will get started. So I've entitled this presentation From Speculum to Self-Swab, a new era in cervical cancer screening. I hope by the end of this presentation, you'll take away 5 learning objectives. So that being describe the epidemiology and pathogenesis of cervical cancer, emphasizing the role of HPV, summarize the current HPV vaccination recommendations and their impact on cervical cancer prevention, review current cervical cancer screening guidelines, explain the technique, benefits, and limitations of the HPV self-swab testing, and lastly, discuss the management strategies based on HPV self-swab results. I have no conflicts of interest to declare for this presentation. So with that, let's begin. So we've made tremendous strides in cervical cancer. However, there's still about 13,000 new cases of cervical cancer diagnosed each year in the US alone, with over 600,000 cases worldwide. Internationally, cervical cancer is the fourth most common malignancy in women. And despite the advances that we have made in its treatment, still in the US, over 4,000 women die from cervical cancer. The most common age of diagnosis for cervical cancer is between the age of 35 and 44. However, interestingly, the average age of diagnosis is actually 50. And that's attributed to over 20% of cervical cancers being found in women over the age of 65. Of note, these are women who have not been participating in cervical cancer screening on a regular basis prior to diagnosis. Cervical cancer rarely develops in women younger than the age of 20. So overall, how are we doing? As I mentioned, we've made tremendous strides. But since the 1970s through the 2000s, we have successfully decreased incident rates of cervical cancer by more than half. However, between 2012 and 2019, cervical cancer rates actually started to increase by over 1% almost every single year in women between the ages of 30 and 44. The reason for that, or at least they suspect, is due to decreased screening rates in the United States, which have been well documented, which began in the early 2000s. Most of those who are not getting screened are from low income or uninsured populations. Despite that, the 5-year relative survival for cervical cancer is about 68%. We talk about cervical cancer, we need to talk about its relation with the human papillomavirus. So a brief little history lesson here. So initially, cervical cancer was hypothesized to be related to the herpes simplex virus, particularly HSV2. However, to no surprise, they were never successful in culturing the virus from cervical cancer specimens. While they were doing that research, they discovered the HPV virus, which is also associated with genital warts. Essentially, two groups of researchers discovered HPV around the same time, and they came to the consensus that they were going to numerically order HPV viral strains in the order in which they were discovered. After its discovery, or after HPV's discovery, Dr. Harold Zerhausen, a German virologist, made the proposal that actually maybe it's HPV that is the cause of cervical cancer. However, after many years of research, he was unable to successfully prove that until 1982, when Matthias Durst, a research fellow under him, was able to successfully culture HPV 16 from a cervical cancer specimen that they had in their lab. After that discovery, they were able to go on and successfully culture that same viral strand, HPV 16, from over 50% of their cervical cancer specimens. Due to the discovery of the association of HPV with cervical cancer, Dr. Zurhausen actually won the Nobel Peace Prize for Physiology or Medicine in 2008. Today, we know of over 200 related HPV viruses, and it is the most common sexually transmitted infection worldwide. They have been able to delineate that there are 12, or currently 12, high-risk HPVs, and those are the HPV viral strains associated with cancer. For cervical cancer, HPV 16 and 18 account for nearly 70% of all cervical cancer cases, with the 5 additional ones highlighted in blue: 31, 33, 45, 52, and 58 responsible for an additional 15% of all cervical cancers. In combination, these 7 viral strains account for nearly 85% of cervical cancer cases diagnosed. So, as you would have guessed, cervical cancer is highly related to being HPV positive. Depending on the study, approximately 95% of all cervical cancers are related to HPV. In general, the rates of HPV positive cervical cancers are increasing, and that's thought to be due to increased detection capabilities. In general, you want your patient to have an HPV positive cervical cancer because there's a better prognosis. HPV positive cervical cancers are associated with squamous cell carcinoma. And the reason for HPV positive cervical cancers having a better prognosis is that the HPV negative ones tend to be diagnosed at later stage and often have lymphatic invasion at the time of diagnosis. Routinely, HPV negative cervical cancers are almost always cervical adenocarcinomas. And adenocarcinomas are the ones that develop from the mucus-producing glands of the endocervix, and they tend to occur in younger females. So we actually have a prevention technique to help against these HPV strains. The HPV vaccine currently protects against 9 different HPV strains. Seven of the HPV strains are the ones that I identified earlier as those associated with cervical cancer. And those are the ones that account for nearly 85% of all cases. As a quick reminder, the HPV vaccine between the ages of 9 and 15 is recommended in a 2-dose series. It's important to remember that that second dose is given at the 6-month mark. If that vaccine dose is given earlier than 5 months, that the patient will require a 3rd dose to complete the series. After the ages of 15, the 3-dose series is recommended, and HPV vaccination can now be continued through the age of 45. If a patient is considered immunocompromised, regardless of age, they should get the 3-dose series. So where do we stand currently with cervical cancer screening guidelines? So the USPSTF guideline dates all the way back to 2018, and at this point is over 7 years old. Now, it's important to note that it is currently being updated and that there was a draft revision posted in December of 24. But the current guideline states that women aged 21 to 29 should get cervical cytology alone every 3 years. And then once they turn 30, it can switch over to either continuing every 3 years cervical cytology. You can do every 5 years high risk HPV screening, or every 5 years of co-testing with HPV and cervical cytology. The preliminary update that was released in December of 2024 for the USPSTF proposed that HPV as the primary modality for screening, and that self-collected and clinician-collected specimens were acceptable. They did state that cytology every 3 years or co-testing with HPV and cervical cytology were a reasonable alternative for screening. But at this point, we haven't seen finalized guidelines from the USPSTF. So for now, it's all preliminary. So stay tuned for an updated guideline, hopefully relatively soon. The American Cancer Society released their cervical cancer guidelines in 2020. And their 2020 guidelines recommended under the age of 25 that no screening was indicated. And between the ages of 25 and 65, that you should screen for HPV alone every 5 years. And once a patient reached the age of 65, if they've had negative testing leading up to that, they could stop with screening. So in general, the US guidelines are pretty out of date. Australia, on the other hand, recently just updated their guidelines in January of this year. And it's possible that it may be a good predictor of what to expect to come here in the US. And so per their new screening recommendations, they recommend screening with HPV testing as the initial test of choice for cervical cancer screening. And then they advocate highly for an informed choice from the patient, and that self-collected or clinician-collected samples produce the same accuracy for cervical cancer screening. So with these new guidelines came the FDA approval of the self-swab for cervical cancer screening. That was the FDA approval came in May of 2024 with 2 systems. The On Clarity HPV system from Becton and Dickinson and Company, BD, and then the Cobas HPV from Roche Molecular Systems. In order to gain the FDA approval for these systems, the samples collected had to be done in a healthcare setting by the patient themselves. So what's the benefits of a self-collected HPV swab? Well, I think the biggest one is that the patient doesn't require a pelvic exam. Since they're collecting the specimen themselves, they may not need an additional appointment depending on workflows in your setting. And the self-swab may be particularly beneficial for patients with limited mobility, vaginismus, a history of sexual trauma, gender dysphoria, or simply if they're not comfortable with the clinician. I think about my male colleague patients that frequently come see me for their women's health needs because they just simply don't feel comfortable with their provider. So this could be a nice option for them to consider that they can collect themselves. So with that said, this test is not for everyone. So who's not a candidate? If the patient has abnormal bleeding, if they have abnormal discharge, if they're having new pelvic pain that hasn't been worked up, and then most importantly, if they've had an abnormal recent HPV or PAP result, they should not be getting the HPV self-swab. So what does the data show? So in general, the data shows that the HPV testing from self-collected vaginal samples have a high relative sensitivity and specificity compared to clinician-collected swabs. Overall, however, the sensitivity of the self-collected swab is lower than clinician-collected swabs, 90 to 93%. However, this difference between the patient collecting the swabs and the clinician collecting the swabs has not been shown to be statistically significant. The data that I have presented here on the right is from the Roche presentation on cervical cancer screening. And in general, you can see that there's a strong association between the results of the clinician-collected swabs compared to the self-collected vaginal swabs. So how do we counsel our patients on how to collect these samples so that we can screen them for cervical cancer. So right now, there's two approved methods from the FDA. The first is the Copen 522C80 swab, which is compatible with both BD and Roche systems. So it's a swab that comes in a dry tube, and on that swab, there's a red mark. And you're going to tell the patient to hold the swab at that red mark and then insert the swab into the vagina until their fingers touch the vaginal opening. At that point, they will take the swab and they will gently rotate it for about 10 to 30 seconds. And then they'll remove it and then place it in the tube and provide it back to the nursing staff so that they can process it. Our nursing staff, or I guess it could be a provider too, will take the swab and open a container of thin prep, place the swab inside the thin prep until the tip is fully immersed in the medium, and swirl the swab around for 20 seconds, ensuring that the swab remains immersed, and then remove the swab, allowing the fluid to drain off, and then cap the thin prep and send it to the lab for processing for HPV. The second option is something called the Evelyn brush. The Evelyn brush is approved to be used with the Roche system. It's a newer swab on the market for cervical cancer screening. And it has these components here. It has this pink cap, the wings, it is a white brush tip at the end, and then the pink plunger. So the patient will take the swab out of the container, remove the cap, insert the device into the vagina. They will push the plunger in so that the bristles come out of the tube, and then rotate the plunger 5 times for 5 clicks, and then they will remove it from their vagina, pull back on the plunger so that the bristles go back inside the tube, put the cap on it, and give the device to the nursing staff for processing. The nursing staff will do a similar job as with the swab. However, this time they'll remove the cap from the device, push the plunger again to allow the bristles to be exposed, and then they will put the bristles inside the thin prep solution, smashing it against the bottom 10 times to enable the sample to be released. And then again, during removal, allowing the fluid to drain off, cap the thin prep, and then send it to the lab for processing. So what are some of the implementation challenges for the HPV self-swab? Well, I think in general, there's going to be some patient concerns, probably amongst our older population the most, just because the cervical cancer guidelines have changed so dramatically during their lifetime. They went from having cervical cancer screenings every single year, and then we told them, hey, you don't need it as frequently, maybe every 3 to 5 years. And now we're telling them, hey, you may not even need a pelvic exam at all, and we can use a swab. I think there may be a little bit of hesitancy, but we shall see. One of the big issues right now is equipment and supplies. In the United States, we should only be using the 2 FDA-approved techniques, and not every institution or lab has that. And so I think that's going to be slow to get. Swabs have been a challenge, and you have to decide which swab that you would like to offer your patient, whether that be that Copen swab or the Evelyn brush. And then once we get this in the system and we can actually use it, we have to update our EMRs to ensure that patients or the data is being adequately processed in the EMR so that it comes off their health maintenance. Ultimately, this project is a collaboration with our pathology department because they have to do the processing of the specimens and ensure validity of the testing that we are providing. So outcomes. So in general, patients who participate in self-swabs, 90% of them are going to be HPV negative and done for screening for that cycle. 3% of them will test positive for HPV 16 and 18, and the recommendation would be go directly to colposcopy. Interestingly, there's some data that says patients who participate in self-swabs are often lost to follow-up. In a Dutch study, patients who participated in self-swabs were at a four-fold higher loss to follow-up than clinician-collected specimens. If the patients are going to screen positive for HPV or concerning findings, and they're not going to follow through, that's of significant concern. So right now, per the Enduring Consensus Cervical Screening and Management Guideline Committee, who recently released an update in February of 2025, they're recommending here in the United States that self-collected swabs be repeated every 3 years if negative. And that is currently, they will clearly delineate that that is an interim recommendation. And that recommendation is due to a lack of long-term prospective data. However, they note if that data comes about, that they feel strongly that the recommendation would likely be shifted to the 5-year mark, consistent with recommendations from other countries around the world. Currently, the ASCCP, the American Society of Colposcopy and Cervical Cancer Pathology, if you use their app for their management of HPV and cervical cytology screening results, it does not currently delineate between provider and self-collected swabs. So something to keep in mind. So I'm going to go back to the Australian algorithm because it's the algorithm that we have on out there currently. And so with their algorithm, like I said, if you screen HPV negative with the self-swab, they say, hey, 5-year screening, see you later. Thus, currently, the recommendations per the Enduring Guidelines is 3 years, but that is subject to change. If HPV is detected and it's not 16 or 18, the patient will then need a pelvic exam so that cytology can be collected so that it can help risk stratify what additional follow-up will be needed. And as I mentioned, if the patient screens positive for HPV 16 or 18, then they would be recommended to go directly to colposcopy, which agrees with the current recommendations for patients testing positive for HPV 16 and 18 through standard testing procedures previously. However, there's a new player. I'm not sure if you saw in the news that in May of 2025, so just 3 months ago, the FDA approved the first at-home cervical cancer screening, something called the Teal Wand. So if a patient decides to use the Teal Wand, they will have to reach out to this company directly so that they can set up an appointment so they can discuss with the provider. And after that discussion, they will be sent the test kit, and then they will collect the sample at home, very similar to the Cologuard, and then the results will be sent to them. Right now, the Teal Wand is accepting some network insurance companies, but even if it is approved by a patient's insurance, it's still about a $99 out-of-pocket cost. If a patient does not want to use their insurance at all for this modality, it's about $250 for either using your health savings account or self-pay. So it's interesting to see, is Teal Wand going to become like the Cologuard that we have to offer for colon cancer screening? Time will tell. So here, our internal limitations at our institution at WVU is that right now we have the equipment in the pathology lab. However, we don't have the swabs available to offer our patients the FDA-approved testing modality for cervical cancer screening. Once the swabs do become available, we'll have to do a brief verification and calibration of the equipment with our pathology department, where the patient will collect a self-swab. We will still do a clinician-collected swab, and they will validate the results between the two and make sure that they correspond. So overall, some key points from this presentation is that in general, HPV screening is now the preferred screening strategy and guidelines worldwide. Self-collected swabs significantly increase screening rates for our patients for cervical cancer. In order to successfully offer self-screening for our patients, it's a collaboration between the nursing team, the primary care providers, and the pathology team for processing. Home kits are now an option for some patients if they have the financial means to do so. And as I mentioned, it's somewhere between $99, $100, and almost $250 if they would prefer to use the teal wand, which is currently the only at-home approved cervical cancer screening. We should only be using FDA-approved testing modalities here in the United States to ensure the validity of the results, the screening results that we are telling our patients. As I mentioned, the current USPSTF and the ACS guidelines are over 5 years old, and there are some preliminary updates out there that are pending, but I anticipate here in the coming year that there are going to be new guidelines, so be sure to have your eye out. But ultimately, as we move forward with self-collected cervical cancer screening, is that we need to empower our patients to make an informed decision and understand the risks and benefits of self-collected swabs so that they can choose what cervical cancer screening is best for them. With that, those are my references. Does anyone have any questions?